Um, Hello, and at any time during the presentation, I probably won't be able to see the chat while I'm screen sharing, but I will come in and out of the presentation. But feel free to just turn your mics off and speak up and interrupt me or ask questions at any point throughout. I'll stop a couple of times. Hopefully this will be as interactive as possible. And I'm very relaxed, just happy to be guided by you guys in terms of what you want to talk about. But anyway, let's crack into it, I guess. All right. Bear with me, I've not actually done like a Zoom presentation before, so we'll see how this goes. Can you guys see that? Yeah, cool. Excellent. So as Gavin said, I want to talk to you about medical management of mental health conditions of the refugees in Greece with a focus on the Aegean Islands. As just saying, this came from the interest in this. I actually did this presentation for my master's that I'm doing at the moment in like a much shorter format. It was like 12 minutes or something. And I sort of expanded it for this. But my interest in this came from the work that I did in Greece, which wasn't that long, to be honest. It was in February, March last year. And so I was working at a primary healthcare organization who provided primary care for the refugees living in Moria. And just found there was anecdotally just a lot of mental illness in the population there, and so we had a lot of difficulties in terms of managing that. So I was interested in looking more into that and finding more out about it. So as Kevin said, this is me, and this is some of my friends in Tanzania, the rural elective in Tanzania that was talked about. So as we said, half of us you already know. Grew up and trained in New Zealand, graduated med school in 2017, went to Tanzania, a place called Moria. That was fantastic. I've always been interested in working in low, middle income countries, and kind of going there confirmed that. It was very intense, very full on. But it sounds cliche, but it was a life-changing experience. It was fantastic. Then I worked for a little while as a psychiatry SHO, senior house officer, for those who don't know that. And that constituted sort of seeing patients after hours, doing mental health act reviews, things like that, admitting patients to a psych hospital. Then decided to come over here to do my master's and travel around Europe, which has obviously been compromised a little bit, but nevertheless, on the way here, worked in a refugee camp called Moria in Greece on an island called Lesbos, and this is what this is about, obviously. And then subsequently come across here, started working in the NHS, and COVID kicked off. I worked in a respiratory ward for a while, and now I'm over in general surgery, doing my Masters of International Public Health. I'm also interested in like other stuff, like non-professionally. Love skiing. Interested in like contemplative philosophy and meditation and stuff like that, and the sort of links between mental health, psychological health, all that, and physical health and family health and all that stuff. Long-term career goal-wise, probably at this stage it's kind of like a toss-up between surgery and psychiatry, so it's a bit of two sides of two very different things, I guess. But I'll probably go back and give surgery a crack first, and then see where we go. Yes, and I'm happy to be asked or ask questions or talk about any of these things at any point, or maybe if it's not to do with the mental health and grief stuff towards the end of the presentation. Does anyone know about Moria at all? Has anyone heard of it, or in the news, or heard of Lesbos refugee camp there? I'll feel free to type in the chat if you like. No, that's all good. Cool. Well, I can tell you about it. All right. There we go. That's Katrina's Healthcare. So that's the organization that I worked with. And what about you guys? So I want to know how many of you guys are medical students? Just speak or type in the chat or whatever. Oh, oops. Or other backgrounds, non-medical students, anything else? Nice. Anyone from like a social science background or law or politics or anything? No. Oh, good. All med students by the looks. Integrating in psychology. Interesting. Nice. All right. Cool. Good stuff. Does anyone have any experience obstetrician in Chad? Nice. We've got someone far more experienced than I am. So cool. MPH student, non-med background. Oh yeah, what's your background? Right. Oh, nice. Excellent. I'll be talking a bit about some stuff that you might be able to help out with later. But we'll see. Okay. Any so we've got obviously the person I missed the name, the obstetrician who was in Chad. Andrea and Mark, one of you or both of you, has experience working in probably low-income, low-middle-income countries. Does anyone else have any experience working in a low-income country, low-middle-income country, or refugee camp? No. Okay. All good. Let's move on. So I'm not very good at this. So first of all, I'll just a bit of a chat about mental illness in general, and then I'll speak about Greece and the migration crisis, the burden of mental illness in the refugee camp. Then I was going to do a breakout session. We could probably just break it up into 2 rooms. That could work. And have a look at the current strategies in place and the barriers to implementing to treating mental health with medicines in the refugee camp, and a bit of an update and look at other camps, and then a conclusion and some questions. So mental illness. So the main sort of mental psychiatric disorders which we would have seen in the camp would have been depression, anxiety, PTSD, a bit of psychosis, and adjustment disorders. Now, there's a lot of overlap between all of these. And personally, I'm not a psychiatrist, obviously, but I'm not the biggest fan of like specific sort of labeling mental illness too much in terms of like putting it in a box, because I think it's a continuum of symptoms, and they're often there's so much overlap between them, and we categorize them for mostly logistical and funding reasons a lot of the time, and really it's people often display an array of symptoms which is hard to fit into one exact diagnosis. But that's a bit of an aside. Most of these diagnoses are based on the DSM-5 or the ICD-10, and these days we tend to understand all illness, but obviously specifically mental illness, through the biopsychosocial model of health, which is this. This is how it's relevant to mental health. So we've got biological components, social components, psychological, and then psychological feeds directly into mental health. I'd argue the biological side does also feed directly into mental health. It doesn't need to really bypass psychology. For example, like if someone's got hypothyroidism or something, then they can become depressed directly secondary to a physical ailment. So it's still even relatively simplistic in my opinion, but it's much better than just a biological model of illness. This is where I think that the psychotropic medications work at that interface between the biological and psychological aspects of health, and that's what we're going to be focusing on. This, excuse my terrible coughing, I had to take it from 2 parts of a PDF on the NICE guidelines. So this is basically looking at why do we care about medicines? Why can't we just use therapy? Why can't we just use CBT, talk it out, whatever? And they are great for mild to moderate mental illness. As you can look here, step 1, step 2, step 3, step 4, get going up in severity. If you look at the medication's part of the management from step 2 upwards, and it's the mainstay of therapy from step 3 and 4. After working in a psychiatric ward and seeing the most severe cases of mental illness, you would not get anywhere trying to use therapy on some of the cases that are really, really bad. They often need to have some medicines to get them off that ledge, so to speak, and be able to engage in therapy. These are some quotes from the doctors who were working at Kitchener's Healthcare where I was working. So I'll just read them out. His family were tying him up each night to stop him killing himself, and I couldn't even give him anything to help him sleep. And they're in front of you, pleading and bawling your eyes out, showing you their prescription from home, and you have to tell them you can't do anything. I'll tell you more about why later. This has been an issue in the eyes of the media for a long time. There's multiple articles about it. It's pretty easy to Google Moria, and it'll just come up with, you don't even need to say mental health, but it will come up with articles relating to their mental health. One of the worst part of it, I think, is outlined in some of these articles. It's speaking about kids attempting suicide. Sorry, I have a bad habit of clicking my fingers. Yeah, the population at the camp is quite young, and they are very vulnerable and end up having terrible mental health. So Greece and the migration crisis. So I'm not sure how much you guys know about the European migration crisis, but effectively it was particularly bad at the onset of the Arab Spring around 2010, 2011, and the beginnings of the Syrian war around that time as well, which was part of that Arab Spring. Basically, we had millions and millions of migrants fleeing circumstances where their lives were at risk, and as they came up through, this doesn't really give a good map, but the mainland of what you can see. Hold on, I should use my mouse rather than my finger. I'm not sure. Can you see my mouse? Yeah, sweet. So that's Turkey, and then below Turkey is Syria, and then to the right of it is more like Middle East. Anyway, Greece is the gateway of the refugees trying to enter Europe. And the EU-Turkey deal in 2016 turned these camps from reception centres to containment facilities. I'll speak more about that in a second. About 50,000 refugees in Greece, but probably more. About 20,000 of those were on Lesbos, which is this guy here, biggest island. That's where I was. And I'm not I'm not sure if you guys remember, but the global financial crisis. I'm not sure if you saw on the news, but Greece got hit particularly hard by that, and their economy turned to absolute garbage around that time. And their public health system was the entire public sector was just crippled, and so they could barely fund their health system for their own people, let alone for this influx of refugees. this is a quote from a Greek government press representative knowing the money, the situation in Greece economically. Like, it's just everyone, like, it's they have no money. And the EU gave Greece a whole bunch of money to help look after these refugees, but I don't know where that went. From what I've seen, it didn't probably go to the camps. By the way, I should probably say, since we're being recorded, anything that I say in this, any views or opinions are my own and not necessarily representative of Kitchenos or any other organisation that I'm affiliated with. EU-Turkey deal. Does anyone know? Oh no! Don't stop. Does anyone know about the EU-Turkey deal? I'm looking at you, international relations person. I forgot your name. Noreen, is that right? Maybe. Does anyone know about the EU-Turkey deal? No, I'll take that as a no. Okay, that's cool. I didn't know about it before this year anyway, so I'm not surprised. Basically, it was a result of the influx of irregular arrivals across the Aegean, the sea, from Turkey and also across the land from Turkey into Greece. Irregular just basically being illegal, so to speak. Which is not technically illegal due to the Refugee Convention in 1950 something, whatever it is, because they're seeking asylum and they're fleeing a dangerous situation. But it's irregular, yeah. Turkey was overwhelmed, Europe was overwhelmed, everyone was overwhelmed, and a lot of people were dying trying to cross the Aegean specifically. So they organized this program where they had an exchange of one-to-one of Syrian refugees. So from one Syrian specifically refugee that they returned from the Greek islands to Turkey, the European Union would take one Syrian refugee from Turkey that was well documented, so it would be like a regular arrival into Europe and be resettled. Now, what that meant was that Greece responded to this by basically moving all of the refugees to the islands. Everyone had arrived before 2016 into the islands, and then all the new arrivals were sent directly to the islands. So these camps got completely overcrowded, and it just resulted in the situation there, the conditions just becoming abysmal. They also took upon themselves to take a stance of rejecting asylum applications at the first instance under a fast-track procedure, under the assumption that Turkey was a safe third country or safe first country of asylum. Human rights groups have been constantly up in arms about this because Turkey is not a safe place for refugees, because they just, as I said here, arbitrarily detain them. They're at risk of refoulement, which is basically means returning them, sending these refugees back to the country where they came from, which is dangerous. So back across the Syrian border. And also there's been reports of Turkish military sort of shooting at refugees trying to cross the border from Syria into Turkey to deter them from coming in. They often can't get access to jobs there. They can't get access to welfare. It's terrible. It's not a good place for it. It's not a safe third country at all. Yes, so that was basically the EU-Turkey deal. These are some photos that I took while I was there in Moria, or in Lesbos, I should say. This was just some graffiti on one of the walls in one of the towns because they couldn't leave the camp. This is the camp itself. This was the original camp around like this. And all of this is just extra sprawl. The camp was originally built for 3,000 people or so. And then at its worst, it's been reported of holding about 20,000 people. So just massive overcrowding. And the sanitary waste management systems all done by other NGOs as well. You can see down here, this is the outside of the camp. This is one of the days this is one of the days I was leaving. On the way in, this was all flooded. So there was basically a stream. There's a stream of this is all feces, by the way. So it was a stream of feces filled water coming down from the camp into the stream on the other side, because all of the sanitary systems were just overflowing when you had a heavy deluge of rain. So yeah, terrible conditions, nightmarish. I'm going to use a pretend case to try and illustrate what it might be like for someone coming to this camp. This person is not real, so there's no confidentiality issues here. So we're going to talk about Nooria. She's a 22-year-old woman from Afghanistan. She's got a history of depression, which was previously well managed, and she's now run out of medication. She's seeking help. She's been well managed on just the standard SSRI. So like, I'm not sure how much you guys know about psychiatric medications, but you have SSRIs, which usually treat depression, anxiety, sertraline, fluoxetine, escitalopram, all that stuff. But which are usually just prescribed by GPs. But anyway, she's run out of medication and she's seeking help. She's got a previous suicide attempt, which is when she first got diagnosed with depression, which was in a previous refugee camp in Turkey. But then she was seen by a psychiatrist at that point and was given medication, and now she's been doing well. All right, we'll leave her there. So now and you guys can do this one. What, based on the situation that I've sort of illustrated for you, what might be the factors which would be negatively influencing these people's mental health in the refugee camp? So think about sort of the psychosocial model and just chuck in the chat box or speak up, whatever. What do you think would be some factors influencing it? Yeah. Yeah. Mm-hmm. Yeah. Good. Yeah, good. Good. Yeah, cool. So those are really good. I will show you. I've just kind of did some off the top of my head of what I could think of. So lack of security in the camp. The refugee population in Moria was largely young men, and they were often there was often fights breaking out, and especially between different ethnic groups. Majority of the people there were Afghan. Then the next most common were Syrians, and then I can't remember. I think it was Somali, or was it South Sudanese? Anyway, basically three major ethnic groups, and they often would have fights breaking out between them, and it was just not controlled. Like I often saw I was suturing wounds of people just getting stabbed. Vulnerabilities, as I talked about kids, there's countless young kids in these camps, unaccompanied minors, and older people who can't look after them, who struggle to look after themselves or are vulnerable to other health conditions. I think there's like one of the agencies reported about 50% of their clients had a history of sexual or gender-based violence towards them. 60%, 66% of them were women, 33% of them were men. So it's to both genders, obviously more to women, but yeah, male and female sexual violence. Conflict affected origin, that's something that contribute to PTSD. Terrible living circumstances we've talked about. Poor physical health, because we're talking about mental health here, but access to physical health treatment is pretty simple at the very end, to say the least. Uncertainty of the future we talked about. Family separation, lack of a social network, yeah, lack of fulfillment, they can't work, there's limited school, and financial instability. So that's good. So the burden, so currently there's, in terms of the refugee health in general and refugee populations, there is not a lot of data on it. Let me have a look. I've got some facts. So there's a meta-analysis which showed that in refugees, PTSD was in 22 to 88.3% of the population. Depression was 5 to 81%, and anxiety 1 to 90%. So it's the range is just ridiculous, right? You can't take anything from that, and it's unclear that whether they're acute or chronic conditions or whatever. The 44% of Syrian refugees met the criteria for major depressive disorder, and that was in a camp in mainland Greece. Mental health presentation trauma here consulted 19 per 100 person years. I mean, you can read all these facts here. So it's a pretty, regardless, we don't have the data, but we can pretty safely assume the burden's pretty significant in this camp of mental health problems. So this is from that study in Greece. As you can see, as you spend more time in Greece before if they're not resettled, by the time you've spent 3 years, you're getting to close to 100% rate of depression, which is obviously not great. This was IRC, this is International Rescue Committee. So this is the percentage of symptoms that they saw. 60% of them thought about committing suicide. 64% of them were depressed. 15% of them were self-harming. So these are probably not quite as bad as what I saw in a crisis service, but they are not too far off. And the crisis service here or in New Zealand is the most severe patients in the community who are getting almost daily follow-up. So let's see if we can do this. In a situation like this, I want you guys to have a chat and have a think about what the best way to dispense psychotropic medications would be in this situation. The potential, what the potential barriers might be, like why might we not be able to do that, and the risks involved. And we'll come back and discuss. Maybe if one of you from each group can have a chat about it. So I will put you into breakout rooms. We'll go till don't have that. I've been talking too long. Anyway, we'll put you into breakout rooms for 10 minutes or so, and we'll come back and have a chat. Okay. I'll see if I can pop between them. I've not done this before, so we'll see how we go. 2 breakout rooms. All right, ready, go.
Nice, that worked out.
Cool.
Yeah, sorry about the numbers, but it should be fine with 2 in terms of like discussions of 5s and things.
Oh, that's cool. That's cool. I mean, it sounds like there's 10 and 20 on the other ones anyway. And as I say, the
Yeah.
other guy was way more qualified than me. So I was like, oh,
So
yeah.
that he's the conference chair of our committee, Rebecca, that's her father. So she grew up in Chad, and her dad is the obstetrician, or her mom, I forget which one. But it's Andrea and Mark, because both of them are her parents, and one is in this, or they might both be.
Oh yeah. No,
Yeah. So
I mean the other guy conducting the other breakout room. At the same time as me. Isn't there two going on at the same time?
Yes. Oh,
The
the other workshop. Oh, I see.
Yeah, sorry, that's what I meant. Other workshop. Yeah. Yeah,
Okay, got you.
the guy who's doing the AIDS talk, he's like published in the Lancet and BMJ. And I was like, oh yeah. Okay, I'm gonna pop into
Yeah.
one of them and
I'll stay here just in case anyone gets kicked out by accident or something.
Cool. Cool. All right. So, does one person from each group just want to have a quick second? Because I popped into both, but does one person from each group want to have a quick spiel of what we talked about? Or they talked about?
I can have a go at what we talked about, and if anyone wants to jump in, they can. We were kind of talking about sort of holistic care and how you would kind of manage both social situations and mental health together, because like a lot of it seems very reactive to the situation you're in, and like how can you realistically address one's mental health when the mental health issue is kind of coming from the social situation they're in.
Yeah, no, that's a really good point. We can do we could do everything we could. We could have the best mental health care in the world at these camps. We could have the best psychiatrists. We could have the best medications, and we could have the best psychotherapists. And people would still be depressed. People would still be anxious. People would still have PTSD because of the situation. So in reality, the situation that's what needs to change. Someone from the other group? I can say if no one else wants to. What I was there for. You guys were talking about the risk of, in terms of starting new medications and the risk of side effects and monitoring and things like that. And the dangers of starting new medications when it's really difficult to follow people up, which is a really good point. Talked about the increased risk of suicide in the first couple of weeks of starting an SSRI. It's an important point. Though what I will say is, which I said to those guys, that a lot of basic psychotropic meds, just like SSRI, and some anxiety controlling drugs and things, their side effect profiles, and they're very safe drugs for the most part, as long as you can do an ECG beforehand. And if people continue to take them, then, and you can check up on them every so often, then it's all good. And check up on them after a couple of weeks. Cool. Let's crack on. You guys doing okay? Hopefully I'm not boring you too much. All right. So currently, what are we doing? What are they doing? What are we doing? We've got most mental health care is provided by NGOs like MSF and IRC. MSF provides a clinic mostly for kids, and IRC sees adults. Now the trouble is they have very, very strict referral criteria. They either have to be a victim of physical, sexual abuse or torture, and it has to be acute onset since arriving to the camp. So anyone with a chronic mental health disorder is excluded. So basically it works by the primary healthcare organizations refer to these other organizations, and then they will either have their own psychiatrist or they'll pay for the private psychiatrist on the island. What about public psychiatry? Well, as I was saying to one of the groups, there's only 4 psychiatrists across all of the Greek islands. One of them is on Lesbos, and there's 1 inpatient psychiatry unit for the entire population on Lesbos, and none on the other islands. So if you need admission in the other places and you're severely unwell, you just won't get it. You just have to wallow in the refugee camp. The primary healthcare NGOs where I was working, we weren't allowed to dispense psychotropic medications. We weren't allowed to give anyone anything like SSRI, benzodiazepines. No, so if someone's having a panic attack, too bad. If antipsychotics, absolutely not. It just wasn't possible. We couldn't do it. The legal framework does allow access to the Greek health services through a temporary health card. And so they could technically be referred to the public psychiatrist and wait 9 months or whatever the waiting time would be. But and UNHCR, United Nations High Commission for Refugees, said the implementation of that falls short. It's just not realistic. GPs won't see them, so GPs won't refer them. They can't see Greek doctors, so they can't get a Greek referral. So it's a bit more on the barriers. So stigma is a big thing, especially from some of the cultures that these people come from. Mental health is like less recognized. We talked about the political legal stuff already a bit in terms of the lack of ability to get to the psychiatrists. Talked about the constrained resources and talked about the strict criteria. Treatment, again, political, legal, logistics, and lack of resources, and language barriers. So the other thing is any mental health, in Greece, any mental health consultation has to be conducted in Greek. So what that means is that you have these people in the camp who speak Farsi, or they speak Arabic, or whatever they speak, and you have to have a translator, and then the translator translates what they say into English, and then you have another translator who translates the English into Greek, so then the person speaking Greek can understand. So it goes through 2 translators who are usually non-medical translators. So you can imagine how much rapport you can build with that, and how much meaning is going to be lost, and cultural barriers. So back to Nooria. So she can't get treatment. She doesn't meet the referral criteria because she wasn't sexually or physically abused, and she was an acute onset because she had it before she came. She can't afford a private psychiatrist, and so she deteriorates, and is one of the many who has another suicide attempt. So other camps. Let's see what it's like compared to other refugee camps in other places, and also in Greece. I am less knowledgeable about this stuff because I haven't been there, and this is just from reading. So on the mainland, there's a lot better access to Greek GPs and Greek doctors and Greek psychiatrists and things, because there's just more of them there. So they can actually get seen there. Though there are very long waiting times and, again, constrained resources. Internationally, in Jordan, so Jordan, Bangladesh, Uganda, there are 3 countries which have massive burdens of refugees there. And one of the camps in Jordan, they can access medications from the GP, and they can access the GPs there, but many barriers, mostly financial, stigma, lack of knowledge, time. In Bangladesh, not sure if you guys have heard about Cox's Bazar, where all the Rohingya refugees are. The MSF has a big health center there and provides specialist and non-specialist care. So they have specialists who will do like the more complex cases and the antipsychotics and so forth, and then they have the non-specialist care who can just provide basic stuff like SSRIs or whatever. Uganda is available, but again, shortage of appropriate medication. So this is relevant to this conference, I guess. So they don't have enough meds, and they have way smaller arsenal. They have way fewer types of meds they can choose from. Staff aren't well trained, and there's a lack of choice. Basically, it's different depending on the context, and it's everywhere. It's not great because of mostly resources, but the Aegean Islands are a special case because of the combination of stuff: the overcrowding, Greeks financial stuff, lack of public resources, and Greek being what we call a strong state, which means they have they are a high income country, and they enforce very strict rules, and it's quite hard to conduct humanitarian activities in these strong states quite a lot of the time. And they stop us from giving out medications. So I'm not sure if you guys, so a bit of an update on the situation, because it's quite different to when I was there. I'm not sure if you guys heard, but last year, Moria, which was housing 20,000 refugees, there were, there was COVID, obviously, and then they locked down the camp despite having no cases there. And they locked down the camp for 6 months longer than the rest of Greece, for whatever reason. There's a lot of anti-refugee sentiment, and in fact, a lot of anti-volunteer sentiment for working in those places by the locals, just because there's just these small islands, and the refugee population is like almost matches them, and they don't have the resources, and there's just quite a lot of friction there. But basically, this lockdown culminated in some people in the camp rioting, and in Japanese, the massive fires which burnt the whole thing down. So at that point, some unaccompanied minors and vulnerable people were sent to the mainland. The rest were left on the street for days and days, just sleeping there. So eventually a new temporary camp was erected by the UNHCR and EU. It's on an old firing ground, so they're still picking up sort of shells and stuff. It's on the coast. I was there in around February, or March, so just after the worst of winter time. But it was cold and windy, and they would just have these big white tents, and they had no flooring, so if it rained, it would just get muddy and they'd fall over, and it was terrible, honestly. So that's where everyone is at the moment. But the EU has now given funding to build 5 more camps on the islands. They say that it's not going to be like Moria, but we'll see. There's still going to be containment facilities. There's still going to be strict entrance and exiting. We'll see. This is a quote from the Médecins Sans Frontières head of mission in Greece. We've said it several times: continuing to clone and repackage the containment model is the best recipe for a catastrophe. It's time to demand dignified alternatives to camps and access to a fair and dignified asylum procedure. Otherwise, those seeking safety in Europe will continue to suffer. I'll skip through this. Basically, the recommendations would be stop having camps like this, get them to the mainland, resource psychiatry on the islands, let us actually prescribe medications to like basic psychotropics, and do some research to find out what the burden is. Like, what are we actually dealing with? Because we don't even know. In conclusion, basically, as I said, it's multifactorial. We don't have enough research, but we can assume that the burden is huge. There's massive barriers to access and massive barriers to treatment. and it's really complex because how strict Greece is with their laws, and there's no political willpower to actually improve the situation from the Greece or the EU. Honestly, they just don't really care, in my opinion. Questions? Anyone?
I've got a question more on why exactly couldn't you prescribe? Was it because there wasn't enough medications available, or be too expensive for the Greek government or the national healthcare system to dispense, or?
No, so all of our medications, for some background, were donated from various organizations. It was illegal, like we weren't allowed to. By the Greek government, like strictly forbade us from dispensing psychotropic medications, so including SSRIs. It's pretty common in refugee camps that to not be allowed to dispense more controlled meds like opiates and sometimes benzodiazepines, but it's usual that they, especially for chronic conditions, you can continue to dispense like antipsychotics and SSRIs. We couldn't do that, so that was the big problem.
And that was just because they just had, you didn't really know why, it was just a random.
Because I guess they say they're gonna, overdose, or it's unsafe or whatever, which is just not in line with the evidence. For evidence, we don't have evidence in refugee camps, but like in overall, yeah, their justification is what we talked about earlier. About the potential like risks of management with these medications, but the other medications have side effects too. I don't know, it's just arbitrary.
Do you know if if there's a similar situation in other refugee camps, or is it only in Greece?
Yeah, so I mean, I was talking about that a bit before, just as the situations, it's as far as I'm aware, there's no other countries that have those laws that you can't do that, but I could be wrong. Those three countries that I talked about, Uganda, Bangladesh, and Jordan. They could see the GP, the local GPs, where they would be able to dispense medications, or the NGOs inside the camps were allowed to. So like MSF has a big clinic in Bangladesh, and they're allowed to dispense medications, and they have the specialist and the non-specialist streams. So then you have a non-specialist stream who can just do basic stuff like SSRIs, and then the specialist one, which are those aren't psychiatrists who see the patients. And then you have the specialists, which is the psychiatrists who will manage the more complex patients, and they can do more tricky medication tinkering and stuff like that.
You don't have to answer if you don't want to, but did this affect staff working in the camps? Because I can imagine just not being allowed to help your patients, knowing what you want to do for them, must be quite difficult.
Yeah, so I think there's a lot of people who want to help anyway, and they do have like Kitchenos at the moment is, well, it's because of all this, everything's dynamic at the moment with them, but they currently fill up with staff until the end of April in terms of volunteers. People still want to work there, but there's not many psychiatrists who work there. I think a lot of psychiatrists would find it difficult. A lot of people find it difficult working there because of what we talked about, and that you can provide the best treatment for these people, but because of the situation, they're like only going to have a limited prognosis in terms of being able to get better. So that can be quite frustrating. Also, it's just, yeah, there's a lot of reasons why people don't sort of come and help, but there's a lot of reasons why people come and do help. I think you just have to realize, going into a situation like that, you just have to realize your limitations and just come to terms with it. That's just part of, I guess, going and working in humanitarian work, or working in a refugee camp, or low income, low middle income settings. They have similar, not similar, different restraints on what you can do and what you can offer in terms of, from investigations to treatment. Like, because the limitations of what we could do is it's not limited to these mental health prescribing. Like, these people couldn't get like elective surgery. You would struggle to get investigations. Like, blood tests would often take, you'd be like, they'd have to wait weeks and weeks to get blood tests done if you needed to. Like, if for anything non-emergent, it was really hard to get anything done. You could send them to the hospital, to the public hospital on Lesbos, if you were concerned about it, like an emergency. And if they needed to treat them, they would, but they were pretty reluctant to take anyone as well. So there's a lot of things that you can't do, but I guess you can only do what you can. That's where the political change needs to come.
Can I say something?
Yeah.
I mean, obviously this is a really horrible situation, and refugees are in a particularly stressful situation as well. But I think to put it in perspective, there's one psychiatrist in Chad, and we have 13 million population. So we're talking like this situation magnified 1 million times over in many lower income countries, I think. And this is really where the kind of huge scandal comes in again. You know, it's just really a huge area where things aren't done, and availability of drugs is really low as well. So yeah, I mean, like you say, the only solutions are really political and much bigger, really, in terms of refugee camps and in terms of access to necessary treatment and health for all these people.
Yeah, 100% agree.
It's just, I mean, I'm not belittling what you're saying and that, but it's just like, this thing is just so huge, really.
Yeah, no, 100% agree with you there. I guess I think that there's been a lot more media attention on the situation in the Greek refugee camps because it's Greece, because it's in Europe. And therefore it's like, how could we let this happen in Europe? Well, personally, I think how could we let anything like this happen anywhere? But I think for me, I mean, obviously I'm biased because the issue was like closer to my heart a little bit because I've been there. I guess the lack of psychiatrists is one thing, and certainly more of an issue in a lot of these like low income and low middle income countries. What really got me was the lack of ability to provide psychotropic medications at a primary care level. But again, that's probably an issue in those countries as well.
Yeah, it really is, and again, a huge stigma around mental health and so on, you know.
Yeah, definitely that stigma is huge.
That's a huge issue, really, as well. Yeah. But yeah, I think I do think that it did seem like you were coming up against an awful lot of like official ideas and rules and regulations that didn't need to be there. There were people capable of prescribing these drugs. They're not particularly expensive, some of them. So it's kind of, why in this situation was it not available? That seemed like it's a relatively easy situation to deal with compared to dealing with the whole of Chad. So why not just get on and get that sorted? I think that's probably really frustrating. Yeah. Exactly. I mean, dealing with Chad is like, it's going to be impossible. So, but this is just something that seems so simple.
Yeah. I guess that's the crux of my point, really. It's a lot of the issues in this camp regarding the supply of mental health medications come down to direct political decision making within Greece and within the EU, and saying we're going to make this law, which is just going to negatively affect so many people, and there's no real reason why we're doing it. apart from just to control.
Yeah, I totally agree. Yeah, totally. Yeah.
But yeah, no, thanks for that. It's really, really, really valuable. I appreciate that. Anyone else? Any other questions about anything else that I've sort of been involved with or talked about or whatever?
Just wondering, why did you choose to go to Greece? I mean, was it just why?
Yeah,
Greece
so
in particular.
yeah, fair enough. Moria was the biggest refugee camp in Europe. Why did I go to Europe? Why did I go to Greece as opposed to somewhere else? I knew people who had gone there with from the hospital where I was working in New Zealand, and it was an organization which took people to, people who weren't specialists to help with primary healthcare, so I was able to do that. I would have struggled to volunteer. I would struggle to get a job with somewhere like MSF, because they tend to just take specialists, or like community workers, and they have specialists and they like local people. And also it was kind of like I guess that's basically it. It was mostly due to just knowledge and having connections and stuff, and that was just an easy first step in terms of where to go.
Okay, that makes sense. And then just wondering from your own experience, your expectations of how the refugee camp would be, did the reality meet your expectations, or was it even worse or better than you imagined?
So I'm trying to remember what my expectations were like. I don't think I expected the conditions to be as bad as they were, I don't think, in terms of the state of the camp. The overall, in terms of like what we could do and how we like the kind of treatment we could provide and stuff, like I think I knew that it was going to be limited, and that pretty much the job, in terms of what the job was, that pretty much met my expectations in terms of like how badly these people were treated. If it was worse. But in saying that, you guys, a lot of you guys are medical students. As much as it was tough seeing that stuff, and it was hard work as well. It was still really rewarding, and I met some really, really cool people while I was there. Everything you do is done with translators, and a lot of them are young guys or girls, and then one of the guys was a doctor from Afghanistan, and met him and met his family. He was there with his wife and 3 kids, and then one other kid who they brought with them, who was from a different family, and just met some really, really cool people, and like learned a lot from them, and had some really fun times, even the relatively short time I was there. So learned about learn a lot about how things work in those situations, and from being on the ground a bit. And yeah, it's a very worthwhile experience in my opinion. And if anyone's thinking about doing it, I strongly would encourage it later on. And if you want to get in touch about like how you might go about doing that, then more than willing.
Yeah, thank you for that. I am interested, but I think, as I mentioned before, I'm a non-medical student, so I don't really, I'm in MPH. I've just finished my MPH. And okay, so your personal experience, do you know if there are any, is it more, I guess, is it an experience more for medical students or medic backgrounds, or are there other areas as well?
No, so there's plenty of other areas that you'd be really valued, like and in some of those organizations, like some of those larger NGOs would they take people on from those backgrounds where you go and work in those refugee camps and things. Where did you do your MPH?
At King's College, London.
Oh yeah, cool. Yeah, because there's loads of the lecturers that we have through our course, which is like obviously international, like it's Masters of International Public Health, so it's more of a focus on these kind of issues. But they have come. A lot of our lecturers have come from doing like the course that I'm doing now, and subsequently gone into organizations like Save the Children or War Child working in Yemen, or Médecins du Monde or MSF or whatever. Like they often get involved with those things, and you end up being in more like a program development managerial role, but still like do much more than a doctor.
Yeah. Do you mind if I could get your email and then
I'll pop it on the chat for sure.
Okay,
and
that's
I'll
great.
do my
Thank
personal
you.
one. And anyone's welcome to email me about anything that they want, whether it be this stuff or about junior doctor work in the NHS or coming to New Zealand or psychiatry or surgery or whatever. Just flick me an email and happy to get in touch. Happy to have a chat.
Do you have any advice about like when in your career it's a good idea to do these things? Like, because do you think it's okay going as a relatively junior doctor, or do you think you're better off waiting until you're a bit more experienced?
You can do different things between like a junior and once you've got more down the line with more experience. Like I was there and doing like, as I definitely wouldn't do it as a like fresh graduate or whatever. Like you'd want to have some experience as a doctor, but like working with Kitchener, working in these refugee camps, basically doing primary care stuff. I'd done ED, I'd done in a rural hospital, so I'd done a bit of surgery, done a bit of this and that. It was fine. Like I didn't ever feel like I was out of my depth clinically, because there were almost always like an experienced GP around, or an ED physician who was coming and volunteering at the same time. Also, and you could ask them questions if you needed to. Also, where was I going to go with that? Oh yeah, I felt more out of depth when I was working in a rural hospital in New Zealand, when I was on nights by myself with one other junior doctor covering a whole hospital, including the emergency department, obstetrics, pediatrics, general medicine, and general surgery. That I felt clinically out of my depth much more there. So yeah, but then later on you can do more specialist stuff. Like they always want surgeons and pediatricians and obstetricians, gynecologists, like these from the clinical perspective, they always want those specialties specifically. But it's about like getting showing your interest, like in terms of being able to be involved in those things. It's about like getting some experience however you can, like attending things like this is great, like reading, being just sort of expanding your knowledge base and understanding some of the issues going on. Read global news, don't just stick to the BBC where it's very like UK and Europe focused. Yeah, Al Jazeera is a good thing to get involved there, but yeah, just do what you can. And I've been like, I did my elective in, as I say, Tanzania. Just as you go through, then I'm not sure is it Andrea has anything to contribute there as well.
I think pretty much what you said is good. I wouldn't, as you say, not to go immediately. It's good to have a certain amount of experience. And I think obviously if you were wanting to offer something like an obstetrician, then you would need to have a certain level of experience.
Yeah.
That was my experience of going as an obstetrician once I was sort of well into my training, so that because you are trying to offer something more than what people on the ground can offer. I mean, if we're talking about my experience, which is not necessarily not really in a refugee situation, but in a more normal hospital situation, then you need to be going and offering something above and beyond what obviously local doctors can do. There are local doctors, there are locally trained people, and then over some of those language issues as well if you've got local people. So you need to know that you're going to offer perhaps some training that you can give to people
exactly
there, rather than just going